Okay, we already have a significant audience, so we will get started. Hello, everyone. Welcome to the GHP Brown Bag. My name is Anna Langer, and I'm a professor of the practicing department of GHP, and also I lead a program called the Women and Health Initiative. Today, it is my very, very special pleasure and honor to introduce one of our wonderful lead colleagues, Mareli Claassen, who will talk about some of her research and the situation in Namibia. Mareli is a clinical epidemiologist and an associate research professor of the University of Namibia, funded as an African research leader by the UK Medical Research Council and the UK Foreign, Commonwealth and Development Office. And she's also a senior fellow by the European and Developing Countries Clinical Trials Partnership to investigate drug-resistant tuberculosis cases findings in the 3 regions of Namibia. She's also a research fellow at Stellenbosch University in South Africa, a research associate at the South African Center for Modeling and Epidemiological Analysis, a member of the Global Burden of Disease Collaborator Network, and a member of the Global Young Academy. Mareli, as I said before, is a 2021 lead fellow through the Harvard Global Health Institute and the Global Health and Population Department at HSPH. So Mareli, welcome. The floor is yours.
Thank you very much, Anna. So for tonight, my affiliation is primarily as a lead fellow, but like Anna said, I'm also an associate research professor at the University of Namibia, where most of my work is based, and most of the talk of tonight will go around the work that we're doing in Namibia. So the outline for tonight's talk is short and sweet. I'm going to talk a little bit about tuberculosis, the past, present, and future, TB in Namibia pre-COVID, the impact of COVID on the TB epidemic in Namibia, our response as a research group, and then I'm going to switch gears a little bit and talk about other impacts of COVID-19, also in the Namibian context, and also then talk about the way forward. So just to get you all on the same page with regards to TB, the first time that we know of anyone who has been diagnosed, in air quotes, with TB was from mummies. About 9,000 years ago, it was in the city of Atlit Yam, which is a city now under the Mediterranean Sea in Israel. And TB was identified in the remains of a mother and child who were buried together. The first written memory about TB is around 3,000 years ago from India and China. In 1834 was the first time that someone coined the term tuberculosis. This was Johann Schönlein. It was also called other things like phthisis, tabus, shachefeth, and in the 1800s, consumption, which I'm sure all of you have heard about. It was also, interestingly enough, called Captain of All These Men of Death. On the 24th of March, 1882, was the discovery of Mycobacterium tuberculosis, the bacilli, by Robert Koch. At that point in time, 1 out of every 7 people with TB died in the US and in Europe. And that's also why today, the 24th of March, is World TB Day, to commemorate the discovery of Mycobacterium tuberculosis by Robert Koch. In 1893, there was the first published report of TB in New York City, and the first nationwide published report by the CDC in the US was in 1953. And at that time, there were around more or less 85,000 active TB cases in the US, much less today. So a little bit of background on where we stand at the moment with regards to testing, vaccines, and treatment. When we want to test for TB, we can either test for latent TB infection or for active TB. For latent TB infection, a skin test has been developed over time. The first time it was adopted in the US was in 1940. Nowadays, we don't necessarily use the skin test any longer. We use interferon gamma release assays, also called IGRAs. For active TB, for years and years, we've used smear microscopy. Nowadays, it's also changed a little bit towards PCR-based tests like GeneXpert Ultra, and the new kid on the block, targeted and whole genome sequencing. With regards to vaccines, we only have one working vaccine at the moment for TB. It's called PCG. It was developed more than 100 years ago in 1921, and it basically just prevents severe disease in children. On the treatment front, before antibiotics, the Italians believed in lena, letto, and latte, which translates into warmth, rest, and good food for TB treatment. Or if you were lucky enough and you lived in either England or France, you could stand in the queue for the royal touch, where one of the royals would touch you and that would reportedly heal your TB. Luckily, nowadays we have a 4-drug cocktail, which in drug-sensitive TB patients would take for 4 months. We also have many other drugs available for drug-resistant TB, but then the treatment period is for much longer. So against that background, that's how we were cruising along in Namibia as well. Using all of these tools that we already have for TB, and our TB program was doing quite well. And that was before something hit. And the big something was obviously the COVID-19 pandemic, which is a curse that we've all had to deal with for the past 2 years already. So in July 2020, you can see the block on the right, on the left in red, shows an article which was published in the Lancet. And this was a modeling study which looked at the potential impact of the COVID-19 pandemic on HIV, TB, and malaria in low-income and middle-income countries. And so remember, this is a modeling study, and this was in July 2020. So at that time, we didn't know a lot about COVID yet. But the findings was interesting. They saw in high burden settings, they estimated that deaths due to HIV, TB, and malaria over a 5-year period could increase by 10%, 20%, and 36% respectively. So in TB's case, that would be 20% increase in mortality over 5 years. And for TB, they estimated that the greatest impact of the COVID pandemic would be on the reduction in timely diagnosis and treatment. So people with TB would not be diagnosed as effectively as was the case before the pandemic, and also not treated as effectively. So then came the Global Tuberculosis Report, the picture on the right from 2021, which reports data from across the world from 2020. And basically, it reflected what was shown in this modeling paper. So in the first place, it showed that almost 10 million cases of TB, of active TB disease, was found in the whole world in 2020. And you can see on this picture, the redder a country becomes, the more cases there are of active TB. So Namibia is right here, over there, that country, and it's already quite red. But because we have quite a small population, we are not as red as some of the other countries, because these are absolute numbers. So this was the number of active TB cases during 2020. And these are not estimates, this is the true number. What it looked like in Namibia, so we have a breakdown of the situation in Namibia. In 2020, around 12,000 people developed TB, 1,400 of them were children. Of those 12,000, almost 5,500 were missing. In other words, they were not diagnosed. And this was up 24% from the previous year, from 2019. We didn't have an estimate of the drug-resistant TB cases. It was not known because diagnostics were not working well during the pandemic. Luckily, the co-infected rate with HIV went down a little bit with 8%, but the number of TB cases who died because of TB went up with 7%. So more or less reflecting what we saw in the modeling paper. If you look at the graphs on top, you can see on the left-hand side, we have not enough money for TB in Namibia. If you look at 2020, the bar in red shows the domestic funding. The bar in green, the little block in green, shows what we have available from the Global Fund. And the long, tall bar in gray shows what our needs are for our TB program. So we don't have enough money for TB programmatic management in Namibia at the moment. If you look at the graph in the middle, you can see that the number of TB cases have been coming down quite nicely since 2010 up until 2020, but during 2019 and 2020, it has stagnated, the red line. And the graph on the right shows the number of people who we've actually found with TB in Namibia during 2020, only 56% of the estimated number of cases. And that reflects back again to the number which was missed. So what happened? Why did we see these drops in numbers? So the figure on the left shows the global trend in case notifications of people newly diagnosed with TB from 2016 to 2020. And you can see there's a huge drop in the number of case notifications from 2019 up until 2020. So in 2019, more than almost 7 million cases notified. In 2020, less than 6 million. And that's a global picture. And it's exactly the same thing that showed in Namibia. So in the graph on the right, you can see Namibia's picture. So the black line gives an indication of the average number of notifications on a monthly basis, not a yearly basis, a monthly basis. And the green line shows for the period of 2020, the drop in the number of cases for each month over that same period of time. So the black line indicates the average, the green line indicates the actual number of cases which were found, and that reflects the same picture that we saw on a global level. And this was basically the impact of COVID-19 in Namibia. So our progress towards milestones and targets were hard hit. The number of people dying from TB increased. Previous declines in annual numbers falling ill slowed down quite a lot. We had fewer diagnosed and treated, also with preventive therapy, and the spending on essential services fell. TB was second only to COVID-19 as a leading cause of death from an infectious agent. And this was not just in Namibia, this is worldwide. And unfortunately, modeling predicts worse numbers in 2021 and 2022. So we're waiting for the next annual report to come out to see what that looks like. So one of the things that we implemented in Namibia during the pandemic, as similar to everywhere else in the world, was the vaccination against COVID-19. But obviously we had the same kind of conversations in Namibia that was done everywhere else. So how do people decide whether they want to be vaccinated? I found this quote by David Hume quite interesting, who said, "There's no such thing as freedom of choice unless there's freedom to refuse." Lots of people in Namibia refused to get vaccinated for COVID-19, and that had an impact on a community level, as we can all imagine. So in July last year, we had a report from the BBC, and this is the report on the right, which basically said that for COVID in Namibia, 15 of my relatives have died. This was during the Delta wave. It was quite hectic in Namibia. Namibia has a population of 2.5 million, and at that point in time, it had the world's highest daily death rate of COVID-19 at 22 per million people. If you can look at the bottom graph on the left, you can see during the same time period, we had less than 5% people vaccinated. So during the Delta wave, when we had a huge amount of people dying of COVID and also hospitalized, very few vaccinations available and very few vaccinated people in country. So I'm just going to talk a little bit about how the COVID vaccine rollout worked. So in March last year, we had Sinopharm and Covishield vaccines rolled out. It was sufficient to vaccinate around 12% of the target population. By the 9th of July last year, all of those dosages were depleted. And I was one of the last people standing in a queue for 9 hours to get my second Sinopharm dosage. Luckily, by September, we had new dosages coming along from J&J through the African Union's Vaccine Acquisition Trust. and also some from Pfizer through the US government. In November, the Sputnik vaccination campaign was suspended after there was a reported association with HIV infection in South Africa. And by the end of November last year, around more or less 20% of our estimated eligible population was vaccinated, but we had a huge amount of vaccines which had to be discarded. Number one, because we got them quite late, close to the expiry dates, but number two, also because there was quite a bit of vaccine hesitancy. And I'll come back to that a little bit later. So how did all of this translate into what we saw as a research group? So as I said before, I'm primarily based at the University of Namibia. This is our research lab. We have a PCR lab, agarose gel lab. We have a sequencing lab, and we're working in very close collaboration with colleagues at Research Center Borstel in Germany for our whole genome sequencing, also at Imperial College in London, and a few other places, which I will hopefully be able to mention throughout the rest of the presentation. So what we saw before the COVID pandemic, we looked at a group of people with drug-resistant TB in Namibia, a group of 136 patients, which was just a not really even a random sample, just a sample that was convenient at that time point. And this is basically what we found after we sequenced the strain genomes. So the maximum likelihood phylogeny was based on the 136 samples that we received from our National Institute of Pathology, which is our reference laboratory. So a little bit more background on the study itself. Like I've said before, we did whole genome sequencing on these samples. The sequencing itself was done at Research Center Borstel, but we did the DNA extraction at our research lab in Namibia. Interestingly enough, we found that 30% of all the strains, the MDR strains, could be found in 2 large clusters, which gives an indication of transmission within the community, and 75% of all the MDR strains were grouped in clusters. Scarily, our pre-XDR strains, 85% of them appeared in clusters. I just want to go a little bit deeper into the detail, which was quite interesting from these sequencing findings. So this is a maximum likelihood phylogeny of the largest cluster of 22 patients. So each horizontal line is a patient. Each colored block is a specific mutation. We have 24 patients in this graph or in this figure. And the 2 interesting things that I want to highlight, there are many interesting things, but the 2 interesting things that I want to highlight is the RPOB L430P mutation, which is the block in blue. And you can see that basically the whole cluster had that block. Apart from one where the block was not colored in, and that was because there was an additional mutation for that specific strain. And then the other mutation that I wanted to highlight was the RV0678, which is the yellow block. And you can see there's a whole group of people also having the yellow blocks, and that's in a smaller cluster. And that's a potential for bedaquiline resistance. And I'll come back to why the RPOB L430P is so interesting in our scenario. So this is Namibia. This is the 14 regions in Namibia, and you can see for the RPOB L430P mutation, basically it appeared in all of these regions. So in each one of these regions, we already saw this mutation. This was from before COVID, so it was samples from 2016, 17, and 18. The frequency of the mutations were higher in the northern parts of the country. And I also want to just highlight that in one of these areas, Otjozondjupa, which is almost in the middle, I want to say a little bit more about that, but I just wanted to show you exactly where that area is. It's quite far away from all of the big centers. And there's a large community of San, indigenous Bushmen, which is what they call themselves, who lives in Otjozondjupa. It's very far away from basically everything. So why RPOB L430P is interesting? It's a borderline low-level resistance mutation, and it leads to 25% misclassification by phenotypic drug resistance testing. So what we use usually for drug resistance testing is not going to pick this mutation up. The DST will just show that it's drug sensitive. And this is quite important. If we want to treat patients effectively, we have to have an absolute clear idea of which drugs they are resistant to. Okay, so to come back to the Otjies-Ontjupa region, which I've just mentioned, this was a report coming from Amnesty International in October last year, and it said that there's discrimination against the indigenous San people, which deprives them of the right to health, as TB poses serious risk to their lives. And basically this showed that there's a hotspot of drug-resistant TB within this San population, extremely high incidence in comparison to the rest of the country, and which we would have to address in addition to addressing the drug-sensitive cases in the rest of the country as well. So just to put that into a little bit more perspective, I'm going to briefly talk about a drug-resistant survey, which was done in Namibia a few years ago in 2014. And it was the second nationwide anti-TB drug-resistant TB in Namibia, survey in Namibia. I'm not going to go into detail, just want to highlight one finding, which showed that drug-resistant TB was detected in 4.5% of new patients and in 7.9% of individuals treated previously. And this was just another indication that we already have transmission within communities, and that resistance doesn't necessarily develop within individuals, but that it's transmitted between individuals. This is quite scary if you compare what we found in Namibia to the rest of the Southern African countries. As you all may be aware, that TB is quite rife in Southern Africa, so we have huge numbers, high incidence countries, high burden countries as defined by the WHO. But if you compare what we found in Namibia to the other Southern African countries, you can see that our proportion of MDR-TB in new patients was 4.5%. And that was second only to the proportion in Swaziland, which is now Eswatini, which was 7.7%. So quite a large number of people relatively to the other countries who already have drug-resistant TB. So other work that we've done in our prospective sequencing study, from the prevalence survey, we estimated that we should see around 840 drug-resistant TB cases per year. In our prospective sequencing study, we found around 23% of that in 2020, the first year of the pandemic, and 27% of 840 in the second year of the pandemic during 2021. And this is an ongoing study. So we know that we have all of these drug-resistant TB cases. We know that we can diagnose them through sequencing, but we also know that the impact of COVID was quite severe. We are now only finding 25% of the estimated number of drug-resistant TB in Namibia. That means 75% are out there, 75% are transmitting. So what can we do about this? And what are we actually doing? An interesting article which came out a few months ago was this article showing that Mycobacterium tuberculosis infection may induce resistance to secondary SARS-CoV infection. This was in a mice model, so it's not been shown in humans yet. But one of the studies that we're working on at the moment is called CORE-NB, and it speaks specifically to this finding. So for CORE-NB, we look at the collision of 3 global pandemics. So we focus on the effect of TB and HIV on the epidemiological, clinical, virological, and immunological trajectory of COVID-19 in Botswana and in Namibia. The picture that you can see on the right is quite striking, I think. It's a picture that a friend of mine took in Cape Town of a patient and her physicians who are talking about her X-ray. She's got TB, and you can see from the way that she looks at that X-ray that she is quite scared. And I think that's one of the things that we try to address not just with for TB, but also for COVID-19 and for HIV. And I just want to remind everyone that, like I said at the beginning, we have a vaccine for TB. It's more than 100 years old. And we also know that COVID-19 combined with our funding shortfalls are having devastating effects on the efforts to end TB by 2030. So we're probably not going to reach that goal. But that's one of the reasons why we are doing this study. So to come back, I want to talk to you about a little bit more detail on this. Basically what we want to do, and we're starting in April, is to look at COVID-19, TB, and HIV in a household transmission study, and look at all these different aspects that I've mentioned before, and also to carry out targeted screening and testing for COVID-19, TB, and for HIV. And this would be in a primary healthcare facility surveillance study. So these are the types of things that we're trying to put in place to address all three of these pandemics that we have at the moment in Namibia, to ensure that we pick up TB cases, but that we also address COVID and HIV at the same time. And this is just a group photo of the regional directorate in the Omaheke region in Namibia, close to the Botswana border. And this is when we visited the regional directorate to explain to them about our work on Core NB, on TB and HIV. And they were very enthusiastic about the work that we're going to do there to find more cases and put them on effective treatment. Our esteemed colleague in Germany, Prof. Stefan Niemann at the Research Center Borsel, tweeted this. He was here in Namibia a few weeks ago, and we did sequencing training for our laboratory technologists from Namibia and Botswana and Eswatini in SARS-CoV-2 sequencing. So underlying for us at our research group is really important to do local capacity building. So we look at the science, but we also look to make sure that we have enough capacity at a local level to move forward in a direction where we can find the cases and sequence them as well. And I just want to briefly mention at this point something about vaccine hesitancy, because I spoke about that before. This report came out now in February 2022, and it was done by the Robert Koch Institute in Germany. And basically what they said was that there's still a lot of vaccine hesitancy in Namibia. And part of Core NB is also going to address this. So our study Core NB, looking at all three the different pathogens and diseases, we're also going to include some information about vaccine hesitancy and try to develop at least with the community members and with the local stakeholders in the Omaheke region interventions to address this. Because you've seen the numbers like that I've showed before, quite a lot of vaccines went to waste because of vaccine hesitancy. Okay, so now I'm going to switch gears, and I just want to say something briefly about scientific travel during the pandemic. So last year I was invited to the World Health Summit to speak also about international collaboration from the global north to the global south. And at that time point in September last year, the only 3 vaccines that were available in Namibia were Sputnik, Covishield, and the Sinopharm one from China. So at that point in time, I had both of my dosages from Sinopharm, but the ones that were accepted in Germany were only Moderna, Pfizer, J&J, and AstraZeneca from the UK, and not the Covishield version. So I couldn't travel to the World Health Summit, although this was a unique opportunity for me also to talk and network to peers. None of us were able to travel for so long. In the end, I had to go through quite nefarious ways of getting an additional J&J booster, even before we had rolled out boosters in Namibia. But I really wanted to be able to speak about what we've experienced as researchers in Namibia. I could attend the World Health Summit, but it was just interesting to me how differentiation on the different vaccines available could influence one's ability to travel. And this was also showcased in the next slide. So like Prof. Anna Langer has said, I'm also a member of the Global Young Academy, and we were supposed to have our annual general meeting this year face-to-face and not virtually. But when we started planning for this in November last year, the country where we were supposed to have this only accepted AstraZeneca, Covishield, Moderna, and Pfizer as their vaccines of choice. And if you look at the picture, which a colleague of mine at the Global Young Academy developed, you can see that of the 200 members in the Global Young Academy, only one member from Africa would have been able to attend have we had this meeting in person. So luckily now it's changed. It will also be a virtual meeting, but that was also interesting for me to realize that there is such a huge differentiation between the Global North and the Global South. So basically only 7 people from the Global North would not have been able to attend this conference had it been in person. Lots of people from the Global South would not have been able to attend. You can see 42 plus 32, so that's 74 from the Global South would not have been able to attend, of those 32 from Africa. So a huge differentiation between access even to scientific conferences, and based on, I would say, interesting but not necessarily equitable ways of making those differentiations. And this was right before Omicron struck. So on the 26th of November last year, we know that the first diagnosis of Omicron came out of South Africa. And basically then travel was banned from all of the Southern African countries. At that time point, I wrote an op-ed for Think Global Health, because I was really quite frustrated with the situation. If you can look at this table, you can see the case rate for COVID-19 at that point in time in Belgium and the Netherlands and some other European countries, also in the UK, and in comparison to some of the African countries. So these numbers are from the 26th of November last year, and this is the day basically that the travel bans were instated. And if you look at the case rate ratio, you can see that the numbers from South Africa and the other Southern African countries, Namibia included, were much, much lower than the numbers in Europe and the UK at that point in time. And still the travel ban was only for Southern African countries and not for these European countries. So this was another example of, I would say, injustice and unfairness. At that point in time, I wrote that the travel bans are based on political agendas and not science, and definitely certainly not on respect for the scientists in South Africa and Botswana who first sequenced the Omicron variant. So what does all of this mean? It basically means that we have to think about this in more than one way, and that it's complicated. So I have mentioned equity and equality. We've all seen this picture on the top right-hand corner about what the differences are between the two things. I've also mentioned vaccine hesitancy in the Namibian context, which played a huge role in the number of people not being vaccinated in Namibia. But as we all know, and as this interesting article in the left bottom corner showed, basically there was an inconvenient truth, and the real reason why most of Africa did not get vaccinated was based on the delivery of vaccines on time within a reasonable time period of the expiration dates, and some of the vaccines that were just not available to African countries at all. For instance, in November last year, when I looked at this, Moderna was only available to Botswana, and even when it was available to Botswana, it got delivered late. So there was huge, I think, inequality and inequity in health with regards to vaccine delivery and how it was rolled out across the world for COVID-19. Okay, so I'm not going to end on this dreadful note. I also want to make a few positive comments on what we can do in future. And I'm going to base this on 3 slides or 3 comments. Basically, I want to talk about agency, scientific collaboration and women in leadership roles. Firstly, about agency, I just wanted to mention that two of the very famous leaders from South Africa, Desmond Tutu and Nelson Mandela, both had TB as children, both survived, and both became advocates for TB. And Desmond Tutu said that we call on the international community, which was so tremendous in its fight against another epidemic, apartheid, to show the same commitment to deal with TB and HIV/AIDS. And I think we can still do that. We can still call on the international community to help us, as, for instance, Namibia as a country in Southern Africa, who have to deal with all three of these pandemics at the same time. But I think with regards to my previous slide, the comment that I made on agency, I think what we should do is we should also call on ourselves, because we also have the capacity within our own communities to build, like I've said previously, technological know-how. That's one of the reasons why we work so closely with our scientific collaborators all across the world, to make sure that we can also start in our own sense, with our own agency, to move forward and not just be dependent on international communities. On that note, I also wanted to make a comment on scientific collaboration. And I've already mentioned a few times that we work wonderfully well with our collaborators. But when I was preparing this talk, I looked specifically at the number of publications coming out of Namibia in the past 10 years on clinical trials in infectious diseases. And this was, I looked at it in PubMed on the 22nd of March, so this is very recent, and there were only 8 papers published from Namibia. So this is, again, showcasing that we actually and absolutely need some capacity building in our communities, at our universities. If we compare this to other Southern African countries, you can see that there are many more papers coming from South Africa, from Eswatini, Mozambique, from Botswana, from Zambia, and basically from all of the other countries as well. So number one, we have to focus on capacity building. Number two, we have to do it in a way where we absolutely make sure that our own Namibian people are trained as first authors and as last authors. Because as you can see here, we had no first or last Namibian authors in these 8 papers, which I found quite shocking at that time point. It's obviously not the only indicator which shows good collaboration, international scientific collaboration, but it is quite a stark indication of how these specific studies were implemented. So I want to move towards the end. I want to show you this paper, which was published quite recently, specifically highlighting the role of women in healthcare leadership. This was a systematic review and a meta-synthesis of multi-sector evidence on organizational interventions. And what they basically found that processes in the organization, for instance, processes around awareness and engagement, mentoring and networking, leadership development and support tools are absolutely crucial to move women forward in leadership roles. And that's one of the reasons why I am now working, while I am a lead fellow at Harvard, on an initiative called WONAM, or it stands for Women in Namibia. And basically it's based on 3 legs, which each of these circles showcase. So one, we want to set up a center of excellence for young female clinicians and public health workers, for them to be trained, specifically in research methods and global health. Number 2, we want to set up a young academy, like the Global Young Academy or something similar, where we can have young female scientists from all disciplines encouraged to become members. And thirdly, we also want to focus on the community, where we want to engage with promising adolescent girls and young women, so that they can be encouraged from a very young age to be mentored and to train in the STEM disciplines. So for those who've been sitting on the edge of your seats, wondering why I've titled the presentation Into the Heart of Darkness, I want to end just on a little bit of a philosophical note. So in 1902, Joseph Conrad published a book which was called Heart of Darkness. And this was a story about a ferry boat captain who traveled into the African interior on the Congo River. And as he traveled down the river, he met with severe sickness amongst the local people. We also had to do with colonialism, which was rife at the time. And he also had to deal with savagery and civilization, and the two in contrast to one another. And it was quite interesting to read through his experiences as the protagonist in the book, obviously, and how he changed his mind about where savagery lies in comparison to civilization. So I'm not going to tell you the whole story of the book. I just want to highlight that what we've experienced during the last 2 years is similar in a sense that we've had to do with severe sickness. We still have to do with colonialism in global health, and we still have to think very carefully about what the difference is between savagery and civilization and where in individuals you can find these things. One of the quotes from the book says, "The conquest of the earth is not a pretty thing when you look into it." I think it's now more than 100 years later from when this book was published. We still sit as a country in Africa with many of the same issues that he wrote about in the book then. And I think I want to challenge each of us who is listening today, myself included, to go back to one of the other quotes that Desmond Tutu has famously said. And this quote says, "If you are neutral in situations of injustice, you have chosen the side of the oppressor." And I want to challenge each of us to make sure that we choose a side at least when thinking about health equity and social justice. And on that note, I am going to stop for questions.
Thank you so much, Mareli, for a wonderful presentation. If you could stop sharing your screen so we can see the audience. Thank you so much. Well, this was amazing. I'm lucky enough to interact with you quite often. So I could ask you several questions and make several comments, but I would rather give a chance to my colleagues here who may have some comments and questions for you. Thank you again. That was wonderful. Please raise your hands, physical hands or electronic hands, whatever works best for you. Okay, let me maybe start with a question and a comment. My question relates to an article that I read today in the New York Times that summarizes lots of articles and points of view of different people about why the pandemic apparently didn't hit sub-Saharan Africa as the world feared it would. And also some hypotheses about what that could have been the case, and also some, I don't know, provocative thoughts about whether to give priority when in a context of limited funding for health to vaccination, COVID-19 vaccination, considering that the pandemic hadn't had such a tremendous effect, the tremendous effect that we were worried it would have, and that instead use it for maybe the other two pandemics you spoke about, tuberculosis, HIV/AIDS, and so many other things. And then maybe the push to vaccinate more people in Africa and even reach that 70% goal was because the global north was worried about Africa being the origin of subvariants that would affect the global north more than the global south because of the obesity epidemic and pre-existing conditions and other things. So that's a long question, and I don't know if you'll have to time to address it all, but maybe you can share some thoughts. And the comment is that about your last part. I haven't followed the literature carefully about what the impact on scientific collaborations and travel opportunities that the pandemic had, but I find that really, really important. And I wonder if you wouldn't, if you and your colleagues are not considering publishing in maybe a high impact journal some of those data and some of those ideas, because I think that's really important for researchers from the global south, and maybe particularly for women researchers. So I'll stop here, and I only took the opportunity of your silence to ask those questions.
So thanks very much. So yes, I think the question around, number one, why did the COVID pandemic not hit Africa as it was projected originally? I think it's very interesting because we were, during the first two waves in Namibia, quite complacent, and we thought that we are not going to be as hard hit. But as I've showed in one of the graphs, I don't know if you can remember, during the third wave, we were actually quite hard hit. At that time point, very few, less than 5% of the population was vaccinated, and we had the highest mortality rate in the world. So at the moment, what we think as scientists from Namibia and from Southern Africa is that we have quite a high number of people who've been naturally infected with COVID-19. And that's why we didn't see as a severe impact of Omicron, for instance. And that's why we're also not pushing as much at the moment for vaccination still, because we already have some of the estimates from South Africa is 80% of the population has already got either natural infection or some kind of vaccination protection, and we have probably around similar numbers. It might be a little bit lower in Namibia. So whether there was really something from the in the African populations themselves who protected against COVID, I'm not so sure, because we didn't see that in our third wave when we had to do with Delta. But I think from then onwards, many people got infected naturally, and through Omicron specifically as well. And I think that's probably made a huge difference to our seroprevalence at this stage. So yes, I would say now to focus still very much on COVID vaccination independently of TB and HIV would not be a good idea. But then again, I was never for the idea of just focusing on COVID-19 vaccination. I always wanted to see it in comparison with the other two pandemics as well. So I do think that one cannot just focus on COVID-19, but then again, we could never just do that in the Namibian and in the Southern African context. And then yes, to your second point, absolutely, we do want to publish that, because I do think it's quite interesting how that was experienced by us in the Global South.
Thank you very much. Any questions or comments for Mareli? Let me go to the others. Yes, Steve, please.
Well, since nobody else is asking for the floor, I can't resist in expressing my intense enthusiasm for this extraordinary presentation. Here we are deep into the scientific analysis of multi-drug resistant TB, and we find ourselves confronted with the heart of darkness, the essence of the inequalities and disparities and social injustice, fundamentally with the great voices of human rights that you mentioned. And as a professor of health and human rights, I want first of all to express my intense enthusiasm for your approach. You're linking those so meaningfully. And secondly, ask you whether in your high sensitivity towards the human rights dimensions of the inequalities that you're talking about, who are your strongest allies, and what are the strongest obstacles? I don't want to, obviously you could write books and books about that, but if there's any partner, if you find either at WHO or the Office of High Commissioner for Human Rights, or you mentioned a study from Amnesty International, quite remarkable that Amnesty International would be addressing a public health issue in Namibia as a human rights issue, spectacularly good. Who are your best allies and who are the ones that we should be focusing our attention on to whose negative impact we should limit? And obviously you've highlighted the nature of scientific publishing, and that is definitely an area where we need to overcome the obstacles. But I wonder if you could reflect a little more about that. Thank you very much again.
Yeah, so thanks. Great question. I think for me, my experience up until now with scientific collaboration, and I'll start there, was positive in the sense that most of the people that we've been working with are very cognizant of these facts as well, and cognizant of the inequalities that are already existing, and working quite hard from their perspectives to, number one, be aware of what we deal with every day, and number two, also put things in place to make sure that they do not do, to use a term that I've heard before, parasite research, but that they rather build capacity within the countries where they work, and quite strongly building on agency, building on autonomy, and building not just on technical skills, but also really to try to build independent researchers in those countries. So I think, number one, for scientific collaborations, that was my experience up until now, that we've had the pleasure to work with people who feel quite similar to what we feel about that. Saying all of that, I think one can choose who you want to work with most of the time. Sometimes it becomes difficult when you are depending on funding from overseas. So at the moment, we're quite lucky. We have never enough funding, but more or less enough funding to at least continue with our work for the next few years. So we're not looking actively for money dropping out of the sky as such. We have good collaborations with people and enough funding. But I think if one becomes more desperate, in the sense that we know that we don't have capacity in Namibia, like I've showed, only eight publications from the past 10 years, and now we want to continue the work that we're already busy with, and say, for instance, in 3 or 4 years we come to a place where we don't have research funding, I think then it becomes more difficult, because then one becomes a little bit more desperate, and as soon as you become desperate, then the power balance changes as well. So that's going to be interesting to see where we go to in a few years from now. With regards to other organizations, we work closely with the WHO in Namibia on COVID, but also on TB. So I would definitely say that our experience with WHO was very positive up until now. We have not such good collaborations with private organizations, so private entities. And I think that's something, especially local private entities, something that we can probably build on a little bit more. Just to come back to my point that we also have to ask ourselves and call on ourselves to not just call on international organizations, but also build local public-private partnerships and work on those specifically to get more local funding. And then with regards to other organizations, I can't, for the heck of me, I can't think of someone specific who has been spoken the wheel as such. But I think more or less, I just wanted to be a little bit provocative by the last few slides, so that each of us can just at least become aware that things are not always as they seem. Sometimes you have to go and look a little bit beneath the layers for where the injustice lies, for where the inequalities lie. And I think that was more or less my point around that. So whether there's a specific organization at this point in time that I want to be wary of, I'm not sure. But I just wanted to, basically open the floor and say to everyone, make sure that you are aware of these things, that they do happen in today's age, even 100 years later after the publication of the book, and that we still have to address them every day.
Thank you, Mareli. I see 2 hands up. We only have 4 minutes left. Julieta is another lead fellow. Please ask your question, and then Dan.
Yeah, thank you, Mareli, for an excellent presentation, well structured, with more information, really, especially on TB. I just wanted to ask, is there maybe way or a research why maybe other social factors that is contributing towards the high rate of TB among the San community in Oshiro-Juba region. Maybe is there other factors rather than being the issue that there is the lack of facilities and other activities?
Yeah, so thanks, Juliet. So we know that amongst the San people, there are quite a number of other factors also playing into the TB epidemic, into the hotspot that we see there of transmission. So most of the people living there are very poor, very marginalized, really in the lower echelons of socioeconomic circumstances. Many of them are quite alcohol dependent as well, they have poor nutrition, not as much HIV co-infection, but yeah, quite a number of other associated risk factors that we can draw close into the picture of why they get TB. But we're also going to do an interesting study about specific genetic profiles of the San people, which might also play a role. But I think that's a whole discussion for another day if you start talking about human genetics.
Thank you. Dan?
Thank you very much for a wonderful presentation. I was in listening to the very interesting things you said about the effect of the crisis in making it harder and harder to identify and track people with MDR-TB and the delays in responding to people with with malaria and many other problems. Would I be off base in hearing a bit of a critique that might go like this, a critique of sort of conventional wisdom that go like this? Look, in Namibia, although we had one phase in which we had a terrible problem with COVID, a lot of the time in Namibia, and maybe more of the time elsewhere, our greatest needs, even COVID related, were really with other diseases rather than with COVID itself. And globally, there's a sense of panic that this is the threat of the hour, and everyone responds to COVID. But actually, in some places, partly a result of COVID, or just for other reasons, the highest priority needs that are unmet are other things. And would I be completely amiss in thinking that maybe we should tune in more finely to the message coming from the countries so that they tell us what their crisis needs are? Or do you think the conventional wisdom was correct here?
No, I think you're absolutely right. Thanks. I think that's a brilliant point. I think we do have to contextualize, and we do have to think for each of the countries which are the most crucial aspects during the pandemic, but also before and after the pandemic. So that's one of the reasons why we are focusing not just on COVID in our research facility, but on all three, because we've known TB for 9,000 years before COVID, and we will probably know it for much longer than the COVID pandemic. And for us, it's crucial to be able to still continue with our TB work, not just as researchers, but as people who care for the people who have TB and who have active TB disease and who are transmitting within the communities. So I think it's spot on. Your comment is spot on. And I think we really have to focus on getting information, contextual information from specific places, and see how we can address specific issues in those places.
Thank you so much, Mareli, for an amazing presentation and for the discussion we had. So we reached the end of our time today. So thank you all for your interest and for your participation. Have a good rest of the week. Bye-bye.